Hello, everyone, and thank you for joining us. My name is Aysun, and I am an editorial fellow at the Journal of Immunotherapy and Precision Oncology, or JIPO, and I am a hematology physician from Turkey. Today, we have an exciting interview here for JIPO YouTube channel. I am honored to introduce to you Dr. Srivastava, who is Assistant Professor of Division Plastic Surgery in University of Illinois at Chicago. And we will discuss her valuable published manuscript in JIPO. The title of this article is Oral Toxicities Associated with Immune Checkpoint Inhibitors, Meta-analyses of Clinical Trials. And again, thank you for being here today, Dr. Srivastava. And let me start by asking you about what is the prevalence of immune-related oral toxicities via by immune checkpoint inhibitors. Thank you for being here again.
Thank you so much for that very kind introduction, Dr. Senturk, and for doing this brief interview with me for the Journal of Immunotherapy and Precision Oncology. It is a real pleasure for me to be here and be able to talk about our publication on oral toxicities resulting from immune checkpoint inhibitors. So, as I'm sure you're aware, within the literature, there have been a lot of clinical reports quite sporadically published about oral toxicities that are immune-related. We are much more aware of other types of immune checkpoint inhibitor-related adverse events, such as the gastrointestinal, endocrine, dermatological, cardiovascular, hematological, musculoskeletal, neurologic, renal, pulmonary, and even ocular adverse events that have been very commonly observed and reported with the use of immune checkpoint inhibitors. At the same time, we are not fully aware of the entire oral toxicity profile of immune checkpoint inhibitors, which are drugs that have really advanced cancer therapy, but still are relatively new drugs when we're comparing it to conventional chemotherapy agents. And that's why we're not entirely aware of what their toxicity profile looks like. Although most trials have reported a relatively low incidence of oral toxicities with immune checkpoint inhibitors, their impact might be sort of undervalued. And the other component of this is a lot of clinical reports have revealed new sort of toxicity events that are not commonly noted with traditional chemotherapy. For instance, there have been case reports on oral lichenoid reactions with or without dermal involvement. For instance, there have been reports on bullous pemphigoid and mucous membrane pemphigoid, erythema multiforme, and even Stevens-Johnson syndrome-like reactions that we're not used to seeing with conventional chemotherapy or even head and neck radiation therapy that are now being noted from use of immunotherapy agents, specifically immune checkpoint inhibitors. So what we did was do a really comprehensive, systematic review of clinical trial data that has been published on clinicaltrials.gov. And we included 93 clinical trials that had published results available for us to analyze to be able to study different oral toxicities, which included xerostomia, mucositis and stomatitis, dysgeusia, dysphagia, oral and oropharyngeal pain, different kind of oral infections, osteonecrosis, osteomyelitis, and any other oral mucosal reactions, as well as angular cheilitis. And we studied this for PD-1 inhibitors, PD-L1 inhibitors, and CTLA-4 inhibitors. And what we realized from these 93 clinical trials is that most of what we're seeing reported in clinical reports have not been found as consistently in clinical trials when we're talking about those pemphigoid type reactions. And the overall adverse events that, the pooled weighted prevalence that we got from doing meta-analyses and all of these outcomes was much lower than what we usually note for conventional chemotherapy or head and neck radiation therapy. So what we noticed was more of a prevalence ranging from 2 to 5% for all these adverse events For instance, for xerostomia, it was 5%. For mucositis, the pool prevalence was only 3%. When you compare it to conventional chemotherapy, where this may be anywhere between 50 to 80% for conventional chemotherapy. So I would say the overall reported adverse events from these 93 clinical trials were significantly lower than what we're used to seeing for conventional chemotherapy.
Thank you. The second question is, what are the most reported oral adverse events and how much of them include high-grade oral toxicities? And maybe we can learn from you, how can we describe high-grade oral toxicities in checkpoint area?
Great. So when we're talking about just describing high-grade oral toxicities, it really is dependent on what grading criteria you are using. And most commonly, even for immunotherapy trials, CTC-AE is the most commonly utilized criteria. When we're talking about what we were able to analyze on clinicaltrials.gov, adverse events are simply categorized as adverse events and serious adverse events. And when we're talking about the prevalence of those serious adverse events, which is what we would consider high-grade oral toxicities here, most reported oral toxicities were low grade. So we saw almost about 2,000 oral toxicity events in these 93 clinical trials, and only about 74 of those and all the events were serious adverse events. So the prevalence, the unweighted prevalence for serious adverse events was only 3.8%. Now, of all the outcomes that we studied, dysphagia happened to be the one that was most commonly reported as a serious adverse event. So there were, out of the 45 trials that we saw dysphagia events being reported, 28 trials actually reported dysphagia as a serious adverse event. And then others like mucositis and xerostomia, they had a much lower, unweighted prevalence of serious adverse events. Another outcome, osteomyelitis. There were 6 out of 8 osteomyelitis events were reported as serious adverse events. So that was an unweighted prevalence was the highest for osteomyelitis, which was 75%. In addition to dysphagia, mucositis, and osteomyelitis, we also saw oral and oropharyngeal pain and oral candidiasis that were reported as serious adverse events, but it was overall, like I said, a very, very small percentage, only 3.8% that was noted as serious adverse events.
Thank you. And the other question, did you observe any differences among subtypes of immune checkpoint inhibitors for oral adverse events?
So very minimal. Honestly, the subgroup differences between our anti-PD-1, anti-PD-L1, and anti-CTLA-4 drugs were very minimal. Although I have to say that PD-L1 antagonists had relatively limited data. So it does introduce some sort of bias when we're looking at it, especially when we're considering unweighted prevalence. And that's why weighted prevalence is so important to analyze in meta-analyses. So for instance, avelumab had one particular study, there was only one study reporting xerostomia, which had 38% prevalence. And then another outcome, it had a 20% prevalence when all the other studies had prevalences closer to 5%. So there's a little bit of bias that can be introduced when we have very limited data within particular categories. But once again, when you pool it and you weigh each of these categories, I want to say there wasn't any significant differences among subtypes, which was, once again, PD-1, PD-L1, and CTLA-4 antagonists.
Thank you. The last question. What are the shortcomings of the data available for assessing prevalence of immune-related oral toxicities?
Thank you. This is a very, very important question. And this is something that as a in studying oral toxicities, not just coming from immunotherapy, from other sort of oncology treatments, what I've realized is oral toxicities, irrespective of their grading, are not always reported in an easy to assess manner. So in most publications, when we're trying to do a systematic review, it is really, really hard to gather this data by doing title and abstract screening like we would for a routine systematic review, because most of this data would very likely be buried in a large table within the publication. And that's why we sort of decided to use clinicaltrials.gov. But once again, we found that the metadata that we derived from clinicaltrials.gov revealed that there was a very high proportion of unreported study results. What I mean by that is, as I mentioned, we've only used 93 clinical trials, which is still a very comprehensive review, but we essentially started with 750 studies that had been completed on clinicaltrials.gov, but out of these, only 270 had any published results. So we're talking about a 64% missing data, missing results data reported on clinicaltrials.gov. So that really limits or basically is certainly a shortcoming when we're talking about assessing anything comprehensively and systematically. Not only the fact that there were study results that were missing, there is no proper format for how adverse events are reported. So there were a lot of studies that were essentially missing certain data elements on adverse events. So you can go to a clinicaltrial.gov record and compare it to a second record. It does not necessarily include all possible adverse events being reported for both the studies. So essentially we had, even off the studies that we had published results available, the ones that had oral toxicity results available were much fewer, especially with single immune checkpoint inhibitor study results. And then finally, another problem that we saw was that there is a very long period, a lag between when the studies are completed and when the first results are made available in the registry, which is clinicaltrials.gov. So all in all of this data availability is certainly the shortcoming when we're trying to access registries for understanding any particular outcome, whether it be adverse events or survival outcomes.
Thank you. It is a good point for a lot of physicians or clinical trials. It was wonderful to talk with you, and thank you so much. And your manuscript will raise awareness about a different side effect of immune checkpoint inhibitors. And I want to thank you, everyone who attended to us. Please, everyone, check out the published article in JIPO and learn from it. It was a pleasure. Thank you.
Thank you, Dr. Senturk. I really appreciate it.